Hello, everybody. My name is Patel, and I'm here to talk to you about liver diseases that are unique to pregnancy. There are six of them, and each of them occur within either the first three trimesters or in the postpartum period. It's really important to understand these diseases because they are unique to pregnancy, but also because they're all diagnosed clinically. So, really understanding the labs and the clinical picture will be really helpful in being able to understand what the next steps should be to treat the mother and the fetus. In the first trimester, we tend to see hyperemesis gravidarum, which is persistent emesis that leads to dehydration, ketosis, and electrolyte disturbances. And it's really managed by rehydrating the patient as well as replacing any electrolytes that are lost. It doesn't really tend to lead to any severe long-term complications for either the mother or the fetus. In the second trimester, we see ICP, which is intrahepatic cholestasis of pregnancy. That's defined as persistent pruritus as well as an elevated bile acid level over 10 within the blood work. It could lead to serious complications such as intrauterine fetal demise within the patient. The American College of Obstetrics and Gynecology does recommend delivery by 36 to 37 weeks, unless a diagnosis is made after the 37th week, at which time you should deliver at that time. And then the mainstay of treatment is UDCA, which studies have shown to help decrease the rate of bile acids in the mother and the fetus, and it leads to symptomatic relief of the pruritus. In the second and third trimesters, and sometimes in the postpartum period, we see the next two conditions, preeclampsia and eclampsia, which is new onset hypertension, so over 140 over 90, as well as organ dysfunction, the classic one being protein excretion in the urine going up, proteinuria. But this doesn't need to be there for diagnosis to be made. These conditions can also be seen within patients that have pre-existing hypertension, if they have worsening of their blood pressure or end organ damage, as we see it within preeclampsia. Eclampsia is really all the symptoms and signs of preeclampsia, but with grand mal seizures. An important thing that we need to important with these conditions is whether they have severe features or not. So in preeclampsia, if there are serious organ compromise and including liver involvement, that is considered severe preeclampsia. And so the management really depends on this classification. If you have preeclampsia without liver involvement or without severe features, you should deliver by 37 weeks. If you have preeclampsia with severe features, which includes liver involvement, then the delivery should be at 34 weeks. And then if you have eclampsia, which is again characterized by those seizures, delivery happens as soon as there's maternal stabilization. Moving forward, the next syndrome we have is HELP syndrome, which is defined as hemolytic anemia, elevated liver enzymes, and low platelets. You tend to see a elevated lactate dehydrogenase, schistiocytes on a peripheral smear, anemia, low platelets, oftentimes under 100,000, as well as elevations in AST, ALT, and total bilirubin. In this condition, one of the things that is really important to know is if the patient complains of hypotension, abdominal pain, or shoulder pain, really should get that abdominal imaging, because that's going to be key to look for any sort of hepatic compromise, such as hemorrhage or rupture or infarction. In these cases, surgical intervention or intraarterial embolization, and in very severe cases, liver transplantation should be considered. And with HELP syndrome, the mainstay of treatment is stabilizing the patient and then delivering, regardless of when it is within their pregnancy. Finally, the most severe and the one we see in the third trimester, sometimes into postpartum period, is acute fatty liver of pregnancy. And this is a obstetric and a medical emergency. It's life-threatening, has a high rate of maternal and fetal mortality, and it's really caused by a fetus deficiency in their ability to metabolize long-chain fatty acids, which can spill into maternal circulation and cause hepatic compromise. The Swansea criteria are a list of clinical and laboratory findings that are unique to this condition. If you have 6 or more of them, you can clinically diagnose fatty liver of pregnancy and don't need to get a liver biopsy. If you do, you will see microvesicular infiltration. It's really important to note the onset of the symptoms and do a quick delivery after stabilization of the mother. The longer the interval between the time the symptoms start and delivery, the higher the rates of complications, including mortality. And finally, the other big thing to really remember is upon delivery, the newborn of a patient that has this condition should be screened for any sort of enzyme deficiency, because if they do have a deficiency within that enzyme, they can have high mortality rates within the first year of life. But doing something simple as such as dietary modifications can decrease that risk significantly. So those are the 6 big conditions that are unique to pregnancy. Thank you very much for hearing me out. You guys have a good day.